So cardiopulmonary resuscitation is carried out on people whose heart has stopped beating. And so cardiopulmonary resuscitation will involve chest compressions. It may involve using an electric current, a shock, to get the heart back into rhythm. It can also involve giving drugs through a drip.
When I'm called to a cardiac arrest and we have to start chest compressions, etc., it's incredibly traumatic. That's the first thing I can tell anyone about it is it's one of those heart sink moments when you know that you have to attend that call. It's often quite chaotic in the sense that there's lots going on, lots of things need to happen very quickly. The chest compressions themselves are quite physically demanding and brutal for the patient, and it's difficult to watch somebody go through something like that. So it's not the nicest procedure to be involved in.
CPR is something incredibly valuable and necessary for many people who might respond well to it. But even in the fit, young and healthy, where CPR might be necessary because their heart or breathing stops, something has fundamentally gone wrong. Their heart has already stopped. You're trying to reanimate them, you're trying to bring them back from a state of their heart and breathing having completely stopped. You're trying to put tubes into their lungs to ventilate them, and for a lot of people I think that is their last time on this planet, and I think that's where we're possibly getting things wrong in Western society as a whole.
So the DNACPR form essentially is an instruction from the patient that he or she, in the event of a cardiorespiratory arrest, does not want cardiopulmonary resuscitation. It definitely doesn't mean that they don't want any other kind of treatment. So, you know, if a patient is admitted and they're dehydrated or they've got an infection, then it's really important that we continue, if they so wish, to administer them, you know, fluids and antibiotics and all of these things that we can do. But then, you know, if their condition doesn't improve with those measures, then what the patient is saying that actually, you know, if my heart were to fail, you know, because of what's happening to me, then you mustn't carry out cardiopulmonary resuscitation. But all other means of resuscitation should still be carried out.
I think the new DNACPR form is initiation of a absolutely vital discussion between healthcare professionals and patients and their families. I think the big fear most people have is not necessarily about death, but it's about those last weeks and maybe months of your life where your control might start to slip away. And that's probably because as a society we've moved away from letting people have the control that they have over their own life and defaulting to medical intervention. And in fact, medicalizing death in many ways as well. So people who are very unwell and who are dying in hospitals, I would perhaps even phrase it like this, are at risk of having cardiopulmonary resuscitation by default.
When you really understand what it's about, you might think twice about what you want. Knowing that you're going to go quite quietly, and knowing that once it's happened that there won't be anything traumatic happening to your body, I think is reassuring, or at least it would be, I think, if it was me. And I think it can be quite empowering because it takes the feeling of uncertainty away as to what might happen.
This is all about the patient, and it's to make things at the end of life as planned and controlled and peaceful and, you know, as optimal as it can be for the patient, so that things don't happen, you know, in a panic. I think that's the thing, that this is all about the patient, and it's only the CPR that we're talking about, not everything else. All the rest of the treatment will be just as it would have been whether we talked about DNACPR or not.
I think fundamentally it's not so much about these forms, and it's not so much about the policy. It really comes down to the conversations that people have about this. The conversations between family members, patients, healthcare professionals, and everyone really talking about death and dying openly. And it might be a difficult conversation, but it is a conversation that should be had really, and wishes should be respected. And that's, all wishes, not just those around the last moments of life, but those around the last weeks of life, last months of life. And CPR forms a small part of that discussion around this advanced care planning for people.